Hi, today is 31st of March, 2023. This event is being organized by The Mentoring, a charity that supports vulnerable people through mentoring in the areas of education, employment, health, and community cohesion. I welcome on behalf of The Mentoring, I would like to welcome all of you and thank you for joining in today. And those who do not know who we are, we try to organize these kind of events off and on once in a month. And this is one of the health information sessions. The purpose of today's session is to provide some education regarding autism, this being Autism Week. We have Dr. Sunil Pulapaka, consultant, child and adolescent psychiatry neurodevelopment service, Cwmtaf, NHS Wales, United Kingdom. Now I can see a lot of people, maybe they would like to chat, so you can say hello to each other or you can have comments on the program that will be welcome. I think we have muted everyone by default, so please be, so that we will not be disrupted by any latecomers or mobile phones. So you can choose to have your camera on or off because this event. So if you would prefer not to be recorded, then you should turn your camera off now. Now, if you'd like to ask any questions, tap the chat option along the bottom of the Zoom panel. I may not be watching exactly what you're talking, but I'll come back to you and then refer the questions back to Dr. Sunil Pulapaka. If at any time your connection drops, you can re-access using your original Zoom link that we have provided, or alternatively, you can use the password and the meeting ID that we have shared with you earlier. Now, over to you, Dr. Sunil Pulapaka.
Thank you very much, Sujata, and the whole TMR team. It's really a privilege for me that. Oh, sorry, my screen is already shared. Is it? Oh, right. Okay. Could I?
I'm sharing the screen, so you can ask me to go to the next slide.
No, we'll do one thing. Could I just use this screen? Is that okay? If you could take off, please, for a moment. Yes. Right, okay. I would like to share this one, if that's okay for you. So, perhaps it's, am I able to do this presentation? Can you?
We can see your screen, Sunil.
Yeah, so I'm trying to present it. 1 second, let me see if I can manage to do this. Okay, can you see my screen now then? The presentation is there, is it?
Yes, yes.
Oh, perfect. Thank you. That's brilliant. Thank you. Right. So afternoon, everyone. Brinanda, thank you very much for this opportunity, really, TMR and team. It's a great privilege. I mean, me being in the child and adolescent psychiatry for nearly 17 years and practicing neurodevelopmental psychiatry for the last 7 or 8 years, I would say, perhaps. I'm here to share my knowledge and expertise, basically, in our day-to-day practices. We've been doing it. Perhaps most of you maybe, having anticipation or understanding about more in regards to adult ASD as well. But let me clarify, it's more about the child and adolescent psychiatry and probably the young people I'll be talking about, as this is our current practice. My sincere apologies. The reason I'm mentioning that as a disclaimer is basically, I'll try to be as much as our current practice is more about a binary practice, like the males and females. No mean, I'm no intention for me to offend anyone, but let me clarify these points to you. And our main assessments are primarily about the young boys and girls, basically. If accidentally, if anybody seemed to be offended, I sincere apologies. I know it's a very sensitive topic about this when it comes to autism. Anyway, so let me carry on then. So I'll try to wind up things to take up a few questions as well, Sujata and team. Is that okay? Right, so let's see if my cursor works to start with. So I just wanted to touch briefly on the neurodevelopmental disorders or conditions, basically. So this is the list of the conditions we do have, out of which one of the main topics which I'm talking to you this afternoon is the autistic spectrum disorder or autism. Can you see my screen clearly, Sujata, just before I move on to the other slides, please? Right, okay. So anyway, so I'm assuming it's visible at the moment.
Yeah, but if you start slideshow, it would be better.
Is it,
Sunil.
I'm trying the slideshow at the moment. Is it moving
You
on?
You have to click keep my version.
Oh no. No, this is another version I'm using. That's why I wanted you to stop sharing. So I want to share my screens basically. That's okay.
Okay.
I'm really sorry.
Or you can try from beginning, extreme left, then it starts off.
So perhaps if you can close, I can start from the beginning from my side. That's what I was surprised actually. Sorry for this. Could you? Right, so I'm trying to share the screen now, so sorry for the blips. I'm unable to move on with the presentation, Sangeeta. Could you kindly help me with this, please?
Sorry, what did you want?
Yeah, you have to click keep this version, keep my version, then only,
keeps
or
you
else try clicking from beginning to your left side, top.
I've tried that basically. It's not allowing me. That's the reason. Perhaps you are sharing
Yeah,
some.
that's what. Keep my no. That's not. We are not sharing anything.
We are not sharing. Why don't we access yours? Why don't we access his laptop, Sangeeta?
No, keep my version. You have to click keep my version.
I've added a couple of slides actually, Sangeeta. That's the reason I was unable to keep your version.
Click and save as file.
Okay, right, okay. Right, so let me see if I can do this.
You'll have to reopen the document.
Reopen the document.
Or if you could close completely and then restart. What do you say? Sangeeta ji?
Sunil is sharing, Yasmin ji. No.
Yeah.
You say no to that. So,
yeah, I've done that. So I am unable to share it from beginning then. No.
You're not able to do it from the beginning if you do it?
It's not allowing me to go.
I'm happy to share if you want to.
Yeah.
No, I am accessing his.
That's right. So if you can begin this presentation for me, Sangeeta, I really appreciate that. Well done.
Open from desktop, Sonal.
Okay. Perfect.
Just close this and open the document from your desktop. Let it save.
Still saving, is it?
Cancel. You have to.
Says it's not responding. Could I perhaps rejoin, or is it working now?
Yeah, check it from the desktop.
It's not allowing me to open. I resume slideshow. Is it clear now? Is it moving? Sorry for this. Can you see the slides moving?
Yeah.
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 Am I okay now then? Okay.
Yeah.
Thanks, Yamuna. Right. So sorry for this hiccup, everyone. Right. I just wanted to quote this. This is a lovely. If most of you would have followed this young actress, Brittany Allen. She's one of the Canadian actress, composer, and a producer. She used this quote. I loved this actually. Autism is always unique, totally interesting, sometimes mysterious. It's a quite an interesting quote, and she mentioned that. I thought I'll just copy here for our session this afternoon. Right. I want to start with there are plenty of definitions about autism per se, but one of the main definition is it's a complex condition with a lifelong neurodevelopmental, especially. It is sometimes referred as ASD. That is what we clinicians commonly talk about. It's called the autistic spectrum disorder. So for our purposes at the moment, I'll use autism. That is what the whole session is all about today. When we say spectrum, it has three important features. That's what we call the triad, which is social interaction, the communication skills, the restricted, repetitive, and stereotype behaviors. So if we just go into the triad first of all, so I've just given some acronyms next to them, so it will be easier for you to understand as well. In terms of the social interaction, the main four components which we have a particular criteria from DSM-5, that is our diagnostic statistic manual, which we use. We often use this manual basically for diagnosis purposes. So these are the four main things when it comes to the social interaction part. It's speech and language delay. It could be verbal or non-verbal languages. It's understanding about the facial gestures, the tone of the voice, lack of use of complex words, or perhaps understanding sarcasm, jokes, etc. In terms of the communication skills, and the second part of the triad, which I was mentioning to you earlier, is about friendships, is about sustaining relationships. It's about understanding some social rules. If they're not written, they struggle to understand it. They find it hard in an unpredictable or uncertain situations as well, and seem to be withdrawn and uninterested in people. So they have their own agenda sometimes. In the third triad of symptoms, basically, we talk about imaginative play in terms of engaging in that. One of the main things, I'll come to that in a later part. They prefer to act out on the same scenes. They like that kind of routine, kind of structures. Again, as I said, cannot cope in unfamiliar situations or unpredictable situations. They have a particular routine, like traveling to school in one particular way, eating the same food, sleeping at the same place, and using the same kind of duvets or quilts and stuff. Their special interests are quite unique, and sometimes they are unusual. They have a lot of sensory aspects. This is an important thing, which also is part of the DSM-5 criteria, which incorporates like the smell, the sounds, the sight, the touch, the taste, the textures, sometimes the dresses they wear and stuff like that. And the most important aspect, again, the last one, which in this concept was rocking, spinning. So they have few stereotypies or mannerisms, what we call them, is whenever they're excited, they start flapping, they try to twirl around, they do some stereotypical movements time and time again. So these are all the main things. I just wanted to show you this. This is just a cartoon again. I adopted from one of my school friends, basically, who shared this cartoon to me. His kid is himself a child, and there are quite a significant sensory aspects, if you notice, in this cartoon as well. Chewing everything. I put my socks just so I maybe never go barefoot. So that's again one of the main sensory aspects. Tiptoeing is one of them. I hate being tickled, so they don't like that close proximity, basically. So they don't want somebody to be touching them without their permission. They don't like haircuts. Perhaps most of some of the kids who go to the hair barbers or the hairdressers, they hate that kind of the tweezers or the sound that the machine makes and stuff. So these are all the same sensory aspects. Right. So how do we come to a conclusion? I mean, as I said, DSM-5, which is the Diagnostic Statistic Manual, we use this criteria, and from the three main domains which I mentioned to you, we at least expect or anticipate to see two of each. Minimum is in the first social interaction part, at least two. In the communication skills part, at least one or more. And one or more in the restricted repetitive, and the sensory issues are a separate category, which also incorporates this. So if young person meets all this criteria, which again, it's not a single person's diagnosis, we have a multidisciplinary team, which has, for example, speech and language therapists, occupational therapists, we have educational psychologists, the school. So these are all the multiple professionals sometimes involved in our own, and including our pediatric colleagues, basically, who do the rest of to rule out genetics or medical conditions for us to come to this conclusion. And then we conclude the diagnosis. Right, so this is just a brief outline. I mean, if I have to speak, I can speak for reams and reams about this topic, basically, which is my passion. But I'll just end. This is her brief information, and I'm happy to take questions and clarify more in the later part. But I just want to touch on some facts, basically. I don't know, I mean, probably you may not have heard about Leo Kanner. I absolutely admire this gentleman. He is an Australian-American psychiatrist who was the first person ever named early infantile autism. This, you won't believe it, it is dating back to 1943. Then nobody has an understanding about it. So he saw some 16 young people whilst working as a child psychiatrist in 1943, I think. It's quite almost so many years ago. He saw the 16 unique kids, basically, and right, they had a uniqueness about they wanted to isolate themselves, sit aloof from other kids, they never engaged. That is when he named this condition. Of late now, it's changed over years, and this is how the other names have come up. And again, I just want to give you numbers as to the awareness and the diagnoses as well. In 1980s, almost 4 decades ago, it used to be diagnosed 1 in 2,500 people in USA. I'm not sure how I didn't see any articles or any evidence that UK they were diagnosing at that stage. So moving again, you can see the number of years, other years pass by. In USA, the current rate is quite much more aggressive, I would say, mind my language. So they're diagnosed much more rapid. In UK, the current prevalence is 1 in 100, so it's roughly 1%. I've given you next to it. In USA, it is the males to females ratio is 4:1, or the boys to girls ratio. And in UK at the moment, with the evidence and the prevalence we're talking about, is around 15:1. I just quoted whoever the article I picked it from. Just to touch on, I mean, this, pardon me for this slide, it's quite a busy slide basically, but the one thing I wanted to give you highlights is what are the likely predisposing factors. I mean, we don't have any particular reason for this condition to happen. It's a heterogeneous. So what I mean by that, it could be caused by many reasons basically, but some of them I wanted to just highlight as these could be some of the predisposing issues. One is definitely for sure, if you can see the third point, which is the gestational age. Whilst mom was pregnant, premature kids or premature babies are likely to have this. They are prone for a risk of chances of having this condition. Maternal health, that is definitely mental health, especially if there are any medications or substances. If there's a sibling with autism, there's a 50% chances of, or 50 to 60% chances of the sibling having the condition. There are a few other conditions, mind me, there are a bit more medical names. Tuberous sclerosis is one of the genetic. Neurofibromatosis is a genetic condition as well. Fragile X is been mentioned there. ADHD, as some of you might be aware or familiar about it. There is another important thing, the newborn meningitis and encephalitis. So it comes under an acute brain injury kind of. So for example, a little neonate or a newly born kid has these infections, they are prone or they're vulnerable for autism condition in a way. So these are all the likely predisposing factors I wanted to just share with you. There are a lot of comorbid diagnoses. I mean, as I said, autism is not a mental health problem. It's a neurodevelopmental condition, but it can accompany many mental health problems. So that is one. So the vulnerability is, if I put it down, anxiety. I mentioned social anxiety. That has very high, 70 to 80% of these young people present with anxiety. That is one of the highlighting one. Yeah, selective mutism. What I mean by that is they don't often speak whilst in the clinic, or perhaps speaking that often. They shy away and they just try to whisper in their carers' ears, perhaps mom or dad. And other important things are obsessive compulsive disorders. That is one likely chance, which is around 30 to 40%. And recently we have noticed quite a significant young people present with gender identity. So this has been a significant concern as well. So these are all, this list is again non-exhaustive. I mean, they're also present with psychosis. So mental health in the sense, schizophrenia, unusual delusions and stuff. So mind me if these are all some words which are a bit more jargony, please don't hesitate to ask me before we finish our session today. I'm happy to clarify. But I just wanted to give you a bit more of this medical terms so that you understand what they are. What happens when, what are the reasons for these mental health problems? So especially there is an evidence here. I did mention intelligence quotient of the young person. The reason is 70% of the young people diagnosed with autism do have intellectual difficulty problems. So what I mean by that is roughly around, I mean, we all have an IQ level of around 70 to 100, so on average, if I put it down. Perhaps most of you might be aware, like Charles Darwin or, well, I mean, Einstein, they're all around 130 to 140 kind of, roughly, their IQ levels are. So what I mean by IQ is that is what I wanted to give you. So a lot of these young people do have either a very high, extremely high IQs, or perhaps they can come under the bracket of under 70 IQ. So this is an important factor for us to remember. It all depends on the level of their intelligence quotient, and this is one of the main concerns for the mental health problems. Obviously, most important thing is, yes, epilepsy is another unfortunate, epilepsy is seizures, the young person having, which also is a likely factor to worsen things or cause more mental health problems because of the chemical imbalance this epileptic fits can cause in the brain. Most important other things are the family factors that I would want to mention it high, because it's lack of understanding or awareness in the families as to, right, why is my son not doing this? Why can't he do this? So this is main thing. When that pressure is fell on the young person's brain, it can take it in a different sense, and they self-ruminate and they start self-inflicting themselves. So these are all some main concerns as well they present with. And obviously the deprivation, the school factors, the peer pressures, the understanding of the school itself. So these are all likely potential for mental health problems. I mean, the main thing about anxiety, I wanted to emphasize a bit on the anxiety. It's a lot of things. These are all, again, jargon in my language, but I want to transfer that in a normal layman terms. So what exactly is this? Why do these young people present with a lot of anxiety? More important thing is they don't, again, as we started talking earlier, that unpredictable situations, or not able to understand other people's emotions. They can't recall all the events. They can't recognize the early signs. For example, when somebody's in my space, I don't know why he's in my space. So that can aggravate my anxiety. So these are all the factors which might be main reasons. So most of the kids, perhaps you might have seen the early years of their life, the separation anxiety. So they don't like to leave mom or dad to go to school, perhaps when they start nurseries, or perhaps when they go to primary schooling. So that is also a type of anxiety. But again, for us to reflect on, yes, that is a potential, there could be a likely feature, but sometimes it can be normal as well. But we don't know. I mean, as they grow older, if things are settling in, it's normal. Part of the milestones and growth, but sometimes it can be worse. But these are the 4 likely anxiety features for us to remember. So what do we do in these situations? I mean, as we all know, no, not one thing fits everybody, isn't it? So that is what we remember. So I have seen, I would say, in my last 7 years or 8 years, I've seen over 600 young people with autism. And none of them matched each other. Every individual is a different presentation. That has surprised me, really, I'm telling you. So in this scenario, so not one blanket fits everybody. So we need to see every individual in a separate context, their flexibility. We need a lot of patience and skill to manage them. They thrive very well in visual. I mean, for example, when I change my voice, hey, how are you? To hi, how are you? So they can modulate. They are very good with the sensory aspects. So they prefer more of a visual kind of cues rather than more of a vocal. The tone of voice makes a massive difference for them. So they get really worried about it. So just wanted to mention that. It's no blanket approach, as I mentioned. So DOMS are, well, we need to build the trust first. So any young person, any individual for that matter, isn't it? We need a trust to be built first. And parents know their children very well. Yes, some of them definitely know about the condition, but we can't get away from the parents. They know their child inside out. So perhaps in the treatment or the assessment process, we definitely rely on the kids' progress and understanding. There are plenty of interventions. I know I can go through reams and reams of these again, but again, as I said, visual aids are quite an important concept. We do try, I mean, there's no particular therapy to one individual, but it's just more therapies about understanding the young person to understand, why am I unique? So giving them an insight as to that you're special about something. So this is what is an important thing we need to give and empower them, really. So for them, gaining that trust, helping them to guide into this is how we need to get them, rather than being, oh, you understand. I mean, these kids do go through a lot of peer pressure, bullying. So a lot of contextually, school is one of the main things, and they tend to refuse as well going to school. So they need that bit of education. So this is what I mentioned in enhanced CBT. CBT is cognitive behavioral therapy. What they do is they encourage the young person to participate. as well as the education to the school, the other local authorities, everybody is an important concept so that we can touch base and help them out. So that is one part of it. And these are all the different tools, and because they are more visual, isn't it? So they need all these worksheets. Thermometer is the anger thermometer kind of thing. So it's from starts from amber to green, or amber to red kind of thing. So these are all the different kind of things. They're perfect. I mean, everything is visual for these young people. The other thing is definitely involving the parents, regular liaison with the school as to how we can put things in place. The unfortunate thing with a lot of the adolescents, once they reach adolescence, because of the peer pressure and stuff like that, they go into a more mode of self-harming, unfortunately. So we do tend to need to work with the parent. So behavioral management is quite important. And obviously their safety is quite important. So we don't know sometimes the present why they're self-harming, what has gone beyond. So a lot of peer pressure is a massive factor, isn't it? And these young people with ASD are very high risk of harming self as well and self-inflicting, because their pain thresholds is unbelievable. I mean, we don't know how much they can withstand a pain. So that is one. And obviously, during these scenarios, I would definitely recommend to attend or ask for help for CAMS professionals, really, right? In terms of the environment, this is just the management in terms of people around them. This is management in regards to environment. So giving them those fidget toys. There are a lot of soft sort of toys and stuff which these young people can access in Amazon, anywhere else you can access this stuff basically. So they have those kind of squeezy toys which calms them down, the anxiety levels to be relaxed. So these can be got on. The other inquisitive one, as I said, we don't often identify girls. Girls is one of the main things we do struggle with for time and time again, isn't it? I know boys present in a different format so far as we've seen. It's a typical textbook, but the girls are quite different. I just wanted to share a couple of points about the girls, why professionals do sometimes miss it. Because the typical male and female behaviors, I mean, the girls are much more quieter, they're content to play on their own. We do see more of boys, basically repetitive behaviors and impulsive control are with voices. Girls hide and put energy into learning social norms. In contrast to boys, again, girls are more likely to form friendships. So they appear to be social superficially, but sometimes they do struggle internally. So this is another reason, because, and as I said, we have two main criteria: the ICD-10, that's the International Classification of Diseases, which we in UK use that format. But again, DSM-5 is more, we adapt the American version as well. There's no particular guidelines or criteria for us for the girls per se. So this is a work under progress at the moment, and I'm hoping a lot of research and evidence will come out. So that is one of the reasons perhaps we are struggling. But again, I just wanted to quote a few things. The girls are quite late to present, basically. So they mask a lot of things in the classroom as well. When we talk about the young people going to schools and stuff like that, they're fine. I mean, no problems in school, oh, hunky-dory, everything. The young person, girl I'm talking about, settled well in classroom. But once she comes home, oh my God, she'll be literally, excuse me, letting it out, quite angry, can struggle with making friendships and sustaining friendships. She is one of the main targets for being bullied as well sometimes. They are more often so, girls are quite comfortable interacting with adults rather than peers of their own age, or perhaps playing with the little ones. We do often notice that and being reported by families. They're often very eager to kind of social rejection is one of the main negatives. So they do feel that they do want to be part of the group, but they are on the fence. They don't know how to talk about. So that is when all the self-image, self-esteem concerns do come up with. So they start tending to internalize the problems. So yeah, they're quite shy, timid, and quite immature in presentation sometimes. We do see time and time again. So it needs parents, or they always catch hold of one particular friend who's the eyes and ears and mouth for her, kind of. So they always accompany them, which is an interesting factor as well. Once that friend doesn't come to the school, she won't attend the school. So that is her safety blanket, kind of. Again, in terms of the communication skills, unlike the stereotypical boys, girls may present with some may not present with language delay, quite because they're quite mature. They have a very good, excellent linguistic abilities. However, they still present with poor eye contact. So ability to see or foresee the consequences, they do struggle with these concepts as well. I'm amazed. I mean, this is one thing we have noticed time and time again in the young girls basically who present to us. Their imagination is way beyond, I mean, their fantasy world. I don't know if anybody heard of anime, the Japanese cartoons and stuff. Excellent. I mean, these girls are all into them. I tried eliciting whatever information I could from them to see why that. They have something, some attraction, because I don't know. I've been trying to read few articles and stuff published, but I couldn't figure out any. So they have quite a vivid imagination. They're excellent artists, actually. And the unfortunate thing is, yes, consequences to these, they are more vulnerable for verbal and sexual abuse sometimes. This is unfortunate, really. There again, the interests and the sensory concepts. As I said, one of them is they're obsessed about anime, and their favorites are pets. I used to have a young person who we diagnosed. She had almost 27 different varieties of pets in the house. You will be surprised to hear. So she loves animals. She gives more love to the animals than the human beings. So the amazing thing about these young people are they're unique, they're special basically, but it's shame that humans can't always understand. So the whole session is all about for us to understand how they present. They're excellent singers. As I said, Brittany Allen, who herself declared to be autistic as well. She's an extremely talented actress, actually. So we do surprisingly miss these things when you see in a normal societal norms. So we need to see them in a different aspect. Then only we'll be able to elicit these out. Right. So in terms of the way they present, again, as I said, same aspects of special interest, the sensory aspects, they're quite intense as well in terms of these. And the most important thing is, yes, they'll end up being bullied because of they dress differently, they have the textural issues. So unfortunately, they get more, because they are more mature than the boys. The depression side, the mood side takes over. That social intimidation, the girls can't cope, basically. I just wanted to finish with these things. These are all some young people whom we took messages or information from. How do they see themselves as being an autistic child? So these were some of the things which they have been telling us, basically. So they understand. Some of them were really quite high functioning autistics, if I put down. In the past, that name used to be called Asperger's syndrome. Perhaps most of you would have heard about it. So this is how they all feel: inability to know when they can trust people. They can't judge that, basically. Anyway, so just these are some of the information I just wanted to share with you, and that ends my presentation. Thank you, TMR, and thanks everyone for listening. I'm happy to take questions.
Thank you very much, Sunil. You'd like to stop sharing the screen so we can
Yes,
see
I'll
everybody,
try
please?
that.
Thank you.
Sorry.
That was a very informative session, and being a Autism Awareness Week, I'm pleased that you have come here to educate all of us here, those who are caring for their loved ones, those who've got autism, and those who are in their professional category where they could help people. So are there any questions I would like to take from the audience? Is there anybody? Yeah, Yamuna has got it, is it? Okay. You have to unmute yourself, Yamuna.
The blanket approach. So it mentioned that it doesn't work, but my nephew, he's 3 years old, and in the school they are applying blanket approach on him. So how if it doesn't work. So I'm just curious as to.
No, very interesting question, Yamana. Thank you. This is what we are trying to work with at the moment. Where I'm based in Kumta, that's around the Cannon Valleys. We are trying to educate the school. I know it's lack of awareness again. Once a young person is concluded with a diagnosis, he has different needs, isn't it, for the other young people in the school. So what we tend to do is, for example, if there are some behavior concerns, this young person may not tolerate the same kind of, well, perhaps exclusion or any kind of things. First of all is the ABCs, the antecedents, behavior, and consequences. So we need to sit with him. First of all, once a problem has begun, the young person who has autism takes time to come out of it. So give them some space, basically. Let them let it out. Let them take their time. Let them calm down. And there will be a one trusted teacher. So for these things, I'll explain to you more, perhaps. A lot of schools have LRB base. I don't know if that what means to you. It's learning resource base.
So he's under IEP, Individual Education
Educational
Plan.
plan.
So he's under observation.
Perfect.
But they are saying they can't diagnose it. They need specialists who can say if he's autistic or not. We don't know that.
Correct.
So I was just wondering how we can.
Yeah.
It's interesting.
Perfect. So what happens is there's a pathway, Yamuna. So we need to get him assessed by, I think you said, isn't it? Is that right?
Yeah, IEP, yeah.
No, the age of your nephew.
Yeah, 3 years old, yeah.
3 is basically, we have health visitors. The pediatrics 2 to 5 is the pediatric age group. So that is where the child health group. The health visitors do the initial assessments, right? They do have an assessment called SOGS, Schedule of Growing Skills. That is what we call it. So once the young person is being referred from the nursery or the preschool to the health visitor, or the health visitor themselves can refer to us, in sense, whichever area, is it Cardiff or Kumtaf, doesn't matter. Every area have these kind of structured kind of clinicians. So once they done the assessment, they can then refer to us, in the sense, for example, I don't know which area you're from Cardiff, hypothetically, if I put it down. So they can get to the Cardiff and Vale neurodevelopmental team. We have pediatric colleagues, or we have the CAMS colleagues there. So they do the initial assessment. So that is how the process starts. Yes, it's unfortunate at the moment the schools can't completely give or put the resources, because they themselves we are really in a austerity at the moment, isn't it? The schools anticipate some diagnosis and then they can put things in place. Okay. So yeah, it's a process actually. So I would recommend you to approach the health visitor. Health visitors are involved until age 5 anyway. The health visitors are in a better position to do the initial assessment and send a referral to the local neurodevelopmental team.
So health assessment.
Health visitors. Until 5, we have health visitors generally. Okay.
Okay.
They do the initial assessment and then the process will start. So that is the best way to start, if I say.
Okay. Thank you.
Welcome.
Can I ask you please something? Can you hear me, Sujata?
Yes, I can hear.
Okay. So basically, I got a friend who got a 4-year-old. He does have, basically, autism means it's like a stigma. Once you say autism, they are afraid. So is there any way you can use a different term so that they don't get offended by using that word?
I mean, mind me asking, I mean, is it okay? Is it Susila Daniel? Is it okay?
Yes,
Sorry, I
yes.
see your name. Right. Okay. Right. Hi. Good afternoon. Thanks for that question. Does he have a diagnosis, or she has?
Not yet.
Not yet. Okay. Right. I mean, it's really unfortunate at the moment, Ms. Daniel. What happens is in UK at the moment, a lot of schools, a lot of educational. So there are different hierarchies, isn't it? The schools, the educational authority, the social services. Everybody understand this terminology, and the importance of the diagnosis. Yes, we can eventually if you are not concerned or if you if you don't want the name or the label of autism, you can always not use it. But at the moment, for them to access support and help, they need this diagnosis. Okay, once the diagnosis is given, yeah, we do ask, a lot of families do come to us, doctor, will it be all right if I don't have it on my records? Fair enough, parents. I mean, we do agree, and a lot of families do come with that request, and we are fine with it, because young people at the moment, they may not know. The 4-year-old may not know, right, what autism means. But perhaps in 10 years or 20 years time, they know, oh, right, oh, I was diagnosed when I didn't know anything. So, but it's just for records, basically, the diagnosis is used. But unfortunately, we are in a situation wherein most of the professionals, the needs can only be met. For example, as Yamuna mentioned earlier, the IEP. IEP can be, this individual educational plan can only be put if a diagnosis is given. This is how we are at the moment struggling in Wales per se. So that's the only reason. But when it's working with the young person, we don't need to name it. Yes, they are special. They are always unique. I bet they are. And that 4-year-old, your friend's child must be an excellent, talented into some things, basically. So just I would expect them to look from his strengths or her strengths and work with it rather than just worried about the name. Is that okay?
Yeah, I am a retired GP from Cardiff. And
Okay.
basically, because I find it's like a difficult area to approach the facilities or the things they are providing, because it's a long road. And then the mentality of the parents are affected because they can't sleep, they can't do anything through the day. So do they have any respite help for them so that the child could be occupied and they can have a little bit of rest? The parents, do they have any of that scheme? It's day and night and 24 hours looking after a hyperactive child. It is very, very difficult.
No. Thank you very much, Dr. Daniel. I mean, this is the unfortunate thing at the moment. So most of the services, or the most services, education, health, well, I know, I'm glad you're retired actually. To be working at the moment in NHS, it is a really, we are chasing our own tails, basically. So the way the austerities have done, a lot of resources are being cut, a lot of funding is gone now at the moment. So until unless a young person gets a diagnosis, that adequate amount of help is not being given. So it is a massive struggle. I'm really sorry to cut long story short. The blunt answer is we don't have any respite. But my suggestion would be is to approach the local authority. I think, I'm not sure, yeah, you must be based in Cardiff, or I don't know, wherever you're based. So approach the local services. Local services do have challenging behavior support teams. So they do have a lot of those support teams, basically. The social services would be ideal. So don't worry, when I mention social services, mind me mentioning, I don't know if your friend is from Asian community, oh my God, social services. I would never worry about social services. Social services have different wings for them. It's just not they will take away the child from them. That's not what their job is. Social services will never do that until unless they assess the risk. We are approaching them and they have challenging behavioral support. They have resilient families. They educate the parents basically in supporting the young person. So these are all the work of the social services do. So they are more resourced than any other organization in UK at the moment. So my suggestion would be is to touch base with them. I mean, on our local websites. Obviously, if it's Cardiff, you'll have on the council website. Go ahead, contact them. These are our concerns, and then definitely they're going to approach you whilst he or she is going through the assessment process. But my recommendation would be eventually is to get an assessment done. It's just for his or her needs.
Okay. Thank you. Thank you so much. Thank you.
We have M. Ali. It says they raised hands. Go ahead.
Good afternoon, Doctor. I was wondering if you could share your thoughts on pathological demand avoidance, profile of autism.
Right. Thank you, Emali. I know I can see only that name anyway. Right. It's an interesting question. Pathological demand avoidance. We are not using that term of late. I think it's rather than, it's called pathological. Pathological sounds really nasty, isn't it? So we call it extreme demand avoidance. It's just a profile at the moment. Yes, it is part of the autism, but I think a lot of our psychology colleagues are working on it. And it is a massive how do I put it down? Investment of the parent, the school, every authority basically to support the parents. It's quite a tricky waters. If I jump in, it has lots to speak about it. Yes, I'm familiar with it. It's part of the autistic spectrum, but it has a different branch to it. So it needs more intensive input and stuff when working with a young person. I'm sorry if that makes sense, Miss Ali.
I mean, I have a child with suffering from autism, a daughter. So, and I do feel she's on the, the avoidance profile. And it's not really something that's diagnosed. So, it's a bit of a struggle with school and
this kind of setup, they need generally a psychological input, Miss Ali. I mean, basically the CBT work, the cognitive behavioral work, working with the parent as well as the young person. So what exactly is, for example, hypothetically putting, right, I put a plate of food in front of you, you need to eat this. I don't like mom, so why are you feeding me that? So just giving a hypothetical example to you. So what we tend to do is we give a different kind of food, which she or he likes. You understand this? So trying to understand slowly the nature. So it needs a lot of intense psychological input for the young person to understand first and then work with it. Yes, it is definitely a massive
I've managed to I managed to manage it quite well at home. So it's the school refusal, which, because that's the part that I don't have an input. So
Yeah.
it's where the challenge comes when in school, because a lot of them are not aware of it or don't accept it, and that becomes a huge challenge because the regular normal interventions for autism don't work.
Mm-hmm. And so I'm sorry, did I miss, did she or he, I'm sorry if it's
It's a daughter, and she goes to a resource space, and
okay.
it was a disaster.
Oh, bless. Okay, right. So she has a diagnosis then of autism as well as the
There's no diagnosis for because I was told that they don't really diagnose it and on the profile, but it's just I see traits of it. So which is why I just wanted to know your thoughts on it, whether it's something that's diagnosed or I don't know how it works with psychiatry or with pediatrics, whether you actually diagnose that part of autism or you don't.
No, we do identify it as a features actually, Miss Ali, but we don't diagnose PDA or EDA. So we don't extreme demand avoidance. We don't diagnose it, but it's a more psychological input is needed. Moving forward, the therapy is quite it needs more intensive therapy basically. Okay.
Thank you. Just had one more question with toe walking, which you mentioned earlier. Is there any sort of intervention to help reduce toe walking? Do you have any suggestions?
Well, I mean, I know I'm a psychiatrist background. As I said, we have a multidisciplinary team here when we're working with the autism kids. My suggestion would be is to go back to your doctors and get a referral to the occupational therapist. They are better in assessing these things. This is a sensory aspect, isn't it? Why is the young person not working with the feet flat? So they're walking with the toes, isn't it? So this needs to be assessed first. So there are sensory concepts which need to be done. The occupational therapists are also part of that occupational therapist. So if you can request the referral, perhaps the GP or...
She was referred to podiatry, but I didn't really get any sort of... So we've seen occupational therapy, we've seen physiotherapy, we've seen podiatry, but I haven't really got any sort of advice or intervention on how to manage.
How old is she? Sorry?
10.
Okay. Because this is a sensory aspect actually. So they do feel comfortable walking this way. And this is one of the main serious sensory aspects of autism actually. So the physios have seen, is it?
Yes. Physio,
they must
occupational therapy, and
some alternative shoes and stuff like that, or perhaps done an assessment.
So I do use orthotics, but at home she tends to toe walk. So it's because outside, because she's got the orthotics, it's fine, I can manage. But at home she tends to tiptoe around, toe walk around. So I was wondering if there's anything that you know of, any tips, anything that I could use.
I'm really sorry, that's not my arena, but I can suggest please follow the orthotics at house as well. It wouldn't change, isn't it? Perhaps being consistent is important for them, isn't it? They thrive
Yeah.
in structure rather than taking it off. I know it's hard at home. We are in a different set of things.
Yeah, I mean, she doesn't wear her shoes at home, so it's with the orthotics. Then because it goes as an insert into a shoe. So I would just thank you. Thanks
My
for that.
suggestion would be as they grow older, the size grows as well, isn't it? It can be massive pressure on the toes and then the feet. So I would recommend it to be consistent. That's all I can advise at the moment. If not,
Yeah.
go back to the allied health professionals.
And you mentioned seizures earlier. Are there any particular type of seizures that you see in autism more?
I mean, we see all. I mean, tonic-clonic are the more common ones. Basically, most of my pediatric colleagues mentioned that to me. The tonic-clonic are serious muscle jerks. But again, that is, I wouldn't say there's one particular kind that, not that I'm aware of. Perhaps probably there must be evidence and research going on. But any kind of seizure is a seizure. I mean, sometimes it's quite difficult to elicit, isn't it? There'll be absent seizures, tonic-clonic seizures, seizures, uncontrolled seizures. There are a lot of different factors there. But if you have noticed any of those kind of things, my definite approach would be to go back to your doctors or perhaps your pediatric consultants. Basically, if there are seizures in the young person, the pediatrics will definitely look into medication and stuff like that. But I don't know much about the seizure side, but yes, it's part and parcel of some young people with autism.
Thank you so much. Thanks for that. It was a lovely question. Thank you.
I think we've got Cordelia. We've got Cordelia. You're muted, Cordelia. Cordelia, you're mute. Yes, thanks.
Yeah. Hello, good afternoon. Oh, hello, good afternoon, Doctor.
I can hear you. Yeah.
Yeah. This comorbid diagnosis, I don't quite get it, which you mentioned. Yeah.
When I say, I mean, as I said, autism is not a mental health diagnosis, Cordelia. Sorry, I can't pronounce your last name. Sorry, I'll call you with the first name if that's okay.
Yeah, Cordelia,
Yeah, Cordelia. So what happens is autism is not a mental health problem, but we have a lot of other, as I said, 70% of these young people present with comorbid, in the sense they are likely to have these conditions. Anxiety is one of them, significant anxiety, social anxiety is one of them. They don't like to go into crowded places. They don't like to go into shopping areas. They like to be isolated in the house. So that is one. There are other conditions like eating problems they can come up with. When I say comorbid, is co-related. So morbidity is, it's also likely to exist. It's a type of different condition, basically. Okay. So that is what it is. And depression can be part of it. They can also have unusual hearing voices, psychosis features and stuff like that. So it all depends on the age range. Probably the little ones may not hear much, but as they grow into adolescence and stuff like that, they can get into those problems.
I have a granddaughter who is about 21. So she's having these symptoms. And then she's quite restless, jumping everywhere and so on and so forth. But this aspect of the doctors putting them on antidepressant drugs, how good and how effective is it, and how dangerous is it to this class of children?
I mean, it's a good question, actually, but we do see, I mean, in children, we don't jump onto medication, first of all. So we do try therapeutic input. The most important model is we try them with therapy, the talking therapy, what we call it. So when we try the talking therapy initially, then we try that for a good 6 weeks or so. And if it doesn't work, then we move on to the medication.
What do you mean by talking? Talking therapy.
Talking therapy is, it's called CBT. I'll give you an example with CBT. CBT is cognitive behavioral therapy. Cognition is the thought. When the young person is anxious about something, I'll give you another hypothetical example. If I have to cross the road, which I've never done it, right? So I can see vehicles traveling this on both the sides of the road, right? So when I have to cross the road, I'm explained as a child as look at your left, look at your right. If there are no vehicles coming, you hold your mommy's hand and cross the road. This is how it has been. Right. So, but a lot of young people have a lot of fears about crossing the road. So for that, what her thought or his thought is, oh my God, if I cross the road, I'll be run over. So that is the thought. So what the behaviors the young person does is, right, okay, let me not cross the road, stay across this road and I'll stay home. I'm say I'm safer, right? So this is where, so we need to alter the thoughts and then the behavior alters as well. So giving them that reassurance to say, young man or young girl, right? So this is how we're going to work. We're going to work with this, right? You'll be safe. You hold my hand. We have done this million times, that reassurance. So this is how the talking therapy works with them. For example, talking in your context about low mood. I'm sorry, I don't work with the adult kind of adults at the moment, but more in the child psychiatry, what we tend to do is we do work with these kind of things. But more often so, the normal cognitive behavioral therapy, which I'm trying to suggest, works with a lot of kids with anxiety and depression. But children with autism, it needs more enhanced, it needs more workup. So it's not just straightforward, yes, I want you to do this, you'll do it. The autistic kids are more rigid, less flexible. So it's not always easy to work with them. It doesn't work in first step. You need to take 10 times or 20 times or 30 times. You need to be consistent. You need to keep working with them. That is when it helps. So in that scenario, we do work with them, or our psychology colleagues will work with. If that doesn't happen, that is when they move on, because their fixation, their anxiety levels are so high. The medication is then advised to bring that anxiety level so that we can work with them. Does it make sense? So it is two-way process, basically. Some people, it starts immediately, the talking therapy. Some people, it may not. So when their anxiety levels are so high, to bring that kind of down, they are generally advised medication. Once the medication goes in, obviously the medication has a reason. The serotonin levels, there are a few chemical messengers in the brain, which can be influenced by this medication. Once that medication helps them calm down, then it's easier for them to work with. Okay. So
yeah, but how long? Because it's a sort of repetitive behaviors. This medication, the side effect, doesn't it affect them to be on a prolonged, period of this medication? The side effect of it. So how long do you put them there? Because sometimes, they put them on endless medication, and that may, sort of throws them to a different scenario, which, does not actually help them as well.
No, I appreciate your question, actually, Cordelia. Basically, in child, we don't often leave them longer. Our main goal is 6 months, or perhaps the maximum is 1 year, and revisit it. I keep on reviewing the young person if I ever put them on a medication, because that is an important concept. We never leave them for more than a year if they not need be, because we revisit it, see how the young person is progressing, how the behavior is working, and how the young person's moods are. We reassess their mental state. This is a process, actually. It's just not one-off. Perhaps in adult psychiatry, I don't know, I won't be able to comment on that. But in child, we ensure that we review them on a regular, because, well, I have children as well. I just don't add medication to even my child. So we need to bear in mind, right, there is a young person, the need is massive. When the pros override the cons, we definitely put them. I know it's overwhelming for all the families, but sometimes it's quite important that this young person's self-esteem, confidence, his mood is definitely not impacting on them. That is when we consider all these factors, do a proper assessment, and then the need obviously brings us to add that medication. Yeah, my practice is ideally I keep reviewing it. You're right. I mean, we do need to ensure that we tend to do, and all our professionals as a medical team, we do review the young person on a regular basis. It's not just we add the medication and leave them.
Yeah. Thank you very much. Thank you.
So can I ask you a question, please, Dr. Saab? My name is Dr. Yasmin Khan. I want to find out, I want to say, in fact, that if you could tell the education authorities that they ought to have autism as a subject which every child has to study, and also the teachers, they ought to have study autism before they get into teaching. I think you can make a point because you got you into it and you know all about autism, and I'm sure they'll listen to doctors like yourself. Are you
Thank
there?
you.
Yeah.
Yes. Thank you
Yeah.
very much, Dr. Khan. I mean, you're 100% right. At the moment, I mean, as you have seen from my figures earlier, in four decades ago, none of us even know about it. Forget about 4 decades. 2007, 2004, our diagnostic rates were quite lower. Of late, because of the awareness, because of our regular reports and stuff like that, it's much more clearer now. Now
Yeah.
the schools are identifying. You're 100% right. My as a consultant, my main role is to work with the team. The team is educational psychologists, the educational authorities. Obviously, that's the main thing. I mean, in the Rwanda Canon TAF, that's where I'm based. We work with the school. I don't know if you are familiar with the names, the SENCOs, the special educational needs coordinators, the
Yeah.
learning needs coordinators. So
Yes.
these people, we train them time and time again. Every 6 monthly, I have a session with them. I go to the schools. They have a group of cohort of schools, cluster schools. I train them so that they educate the teachers. I know because of the pressures and the resources and stuff like that, and obviously, you know, current austerity measures, isn't it? We are going through a tough time to get this pattern to go back. Pre-COVID, we were very good. After COVID kicked up, we lost a lot of those kind of relationships. So I'm trying to rebuild that. I 100% agree with you. We all work as a team. I know, no disrespect to anybody. Most of them are aware, but perhaps because of the lack of resources, may be unable to put things in place, Dr. Khan. But no, I'll definitely ensure that it's going to happen.
Yes.
Dr. Sunil, is
Dr.
there a
Sunil,
training for parents?
Yeah.
So can I just put in one more thing? Dr. Sunil, you know, with the ethnic minority, as we are having these children, we are accepting the fact that they have got autism. So if you could have little talks about autism at different areas, that would be very good. You know, it will help people. So
yeah, I come from the Asian community, as you can see, Dr. Khan. Obviously, that is important because mental health or anything related to around that brain is a stigma for most of us. Even forget about brain. I mean, we have even a diabetes, a hypertension in itself is, oh, none of us, how often do we come and share? Oh, I have sugar problems. How often do we say that, isn't it? So, I mean, anything personal is quite tricky for us. No, I'm willing to participate. I mean, with obviously, I mean, I'll work on. I'm working with TMR, Sujata, and a team. So
that's fantastic.
I mean, it's a privilege to share whatever knowledge I have and help the local communities. That's all I'm working for, actually. And really, thanks for the advice, Dr. Khan. I'll definitely bear that in mind.
Okay, thank you. Sorry, Sujata, I interrupted
No, that's
you.
fine. No, thank you, Yasmin. Anybody else have got any questions? I've got one question. If anybody has finished.
I just had one quick question related to what you just spoke about, anxiety. Since you've got experience in, pediatrics, have you observed, like in your observation, with children with anxiety, does it get worse with age or does it get better? What are your thoughts on that?
Thanks for the question, Miss Ali. I mean, it's age related, isn't it? Every age has its own requisites, isn't it? Every age has its own demands. You understand where I'm coming from, right? So nursery age is different to the preschool to primary to the secondary to once you're adult. So every age is its own. So everything brings a new challenges for me. If I'm coming from an autistic background, oh my God, this changes, I don't even know how I can manage, how can I cope. For example, even from a nursery to primary school, the young person, I mean, I'll give you a hypothetical example again. We ensure that the young person visits the primary school 10 million times before she or he literally transitions to the primary school. That is an important concept, right? So same with primary to secondary. Secondary is again different kettle of fish, isn't it? They need to see almost 11 lessons. They need to see different classes. They need to go to different classrooms. So the best pathway for all these anxieties, yes, every little phase of their life, they have different anxieties to face. We all face that, isn't it? Day in and day out. So it's important for us to understand his or her needs and do that kind of anxiety management work at home. It starts at home, basically. prepare them. What are the needs? What are their strengths? What are their weaknesses? And work on those strengths basically, and try to guide them so that they adapt them eventually. Remember one thing, never step, I mean, Rome was not built in a day, right? It takes time. We need to work so many times for these people because they need to build trust first. They need to build a lot of work up first, and then that is how they work with it. So it takes time, Miss Ali. Yes, I agree with you. The anxieties are a massive features with these young people.
Thank you. Thanks for that.
Yeah.
Yeah.
I've got one question.
Yeah, go on.
We do get referrals who are minor, and then once they reach 17 years, we find it very difficult. Where do they go? Where do we refer them? And I don't think there are many charities or many organizations where we refer them or signpost them. So any?
Yeah. Thank you very much, Sujata. That's a lovely question. Actually, this is where we do struggle as well. So because of the current waiting list and stuff like that. So what happens is when we have a 17 plus 6 months, so 17 and a half years old young person, almost due to be moving into adulthood.
Okay.
So what we tend to do is at the last slide, I mean, if you remember, if you could put that back, it's here in front of me. Anyway, it's called autism.org.uk. That is one website. I would definitely, if you can put it on the chat box, perhaps people can access it. The other one is autismwales.org. So the reason I'm mentioning the autismwales.org, they put in brackets IAS, it's Integrated Autism Service. What these services do is they are based every part of Wales, actually. They have Swansea, they have Cardiff, they have Cwmtaf, everywhere they are based. So any individual 17 years old, if they themselves notice, oh my God, I think I might have features, somehow I managed to thrive through all the way through my primary school, secondary school, let me get assessed. So they can do a self-referral for themselves, going to this IAS. If you browse this website, the local areas, for example, Cardiff, or they might be in Cwmtaf, or they might be in Swansea or Bridgend, anywhere, they can access these services. They can do a self-referral for themselves to get assessed. Okay, this team is called IAS, and they are funded by the Welsh Government and Public Health Wales. So that is an easier access.
This is very difficult. Self-referral is the worst thing our ethnic minority people do, because as it is, they've got stigma. Most of you have already mentioned that. But that's the process. So we need to encourage and push them to go and approach those organizations.
Yeah, perhaps from you work for the TMR, isn't it? Your goal is basically cohesive communities and supporting those teams, isn't it? Perhaps you can ask this gentleman or the lady who wants to get that assessed, perhaps being next to them supporting. I think that will be always accessible. I think that is the best part. I know it's quite difficult stigma, isn't it, for most of us? But it's good if you have supporting teams like TMR. They'll definitely be helpful to move forward.
Anybody else has got any questions?
Yeah. Sujata, can I ask one?
Of course, go on.
Yeah, okay. Doctor, sorry. Oh, sorry. Okay, Vaishali, you can go, then I'll ask.
Thank you so much. Dr. Sunil, I'm a homeopath from India. I'm medically trained from India, and I've worked with from Dr. Barwalia. He runs it's a alternative medicine. Have you, in your experience, seen any role? I have worked and I've seen, but I just wanted your input on it.
Thanks a lot, Dr. Shah. I mean, my input about homeopathy or Ayurvedic medicine, well, when I grew up in India as well, so I don't know much apart from my mom giving me some Ayurvedic medicines and stuff like that. So personally, I'm more of an allopathic doctor, so prescribing our normal conventional allopathy medications. I'm not familiar at the moment, or that any evidence published per se from the research side as any of these sites. But if you have any experience, if you have seen some benefits with the kids with autism and anxiety, has definitely benefited them to calm them down, to help them to self-regulate their emotions and stuff, please do share with us. I would love to hear from you rather than me commenting anything on it. So personally, I'm sorry, I don't have any experience from the.
The whole idea was to just connect, and I think respecting the fact, definitely it is not, as you said, Rome was not built in a day. So it's a more of a cohesive and an integrated approach. And there is a good institute called Spandan, which has worked with Ayush in India and has a lot of research being done there and supported. So yeah, I would love to come back with more evidence-based data for you, which and it could be not, you're not trying to in making just the quality of life better by addressing the anxiety and things like that and self-harming procedures. But no, it was just nice to know whether you had any input, whether when patients came to you, were they using any alternative medicine, anything that you would have?
No, not that.
Okay. Anyways, I'll take the details from Sujata, and I'll definitely would like to connect. Thank you, Sujata. Thank you.
Thank you, Vaishali.
I got a small question, 2 questions, please. Febrile convulsions, do they have anything to do with the autism? Febrile convulsions.
Yeah, that's a good question, Dr. Daniel. I mean, there is some evidence at the moment they're generating, and the research is ongoing at the moment. So febrile seizures depends on how often they were, how many attempts they were. Again, I mean, any seizure is a trauma to the brain, isn't it? We all agree with that.
Mm-hmm.
So there is some evidence at the moment with ABI. It's acute brain injury. So there is a likely potential. I didn't come across any particular evidence yet. I'm working with my pediatric colleagues. So perhaps, so if I come across any of those evidence, I'll definitely get back to you. But yes, I mean, I'm assuming again, it's a brain injury, isn't it? Basically, is that right? I'm sorry for mentioning that word. I'm sorry, very shocked about it. But febrile seizures in itself is a type of fits.
Yes.
So it's a temperature fits, what we call it, is in layman term, isn't it? Any child having that, it has a consequence to it, isn't it? So, but I don't have any evidence at the moment for me to share with you, Dr. Daniel, but would definitely will come back with some points about it. All right.
As the child is growing, the myelination happens in the brain. Then they say they'll be out of febrile convulsions. So whatever acute brain injury happens before, say, 5 years, that can get better after 5 years, you think?
Well, hopefully, it depends again on the myelination, because the main causes, I know I didn't talk about, probably I can see a lot of laymen or lay people around on this on our chat today. That's why I didn't use many of the medical jargon terms. But as we all know, pathophysiology of ASD is quite it's a quite complex presentation. It could be immune related, it could be neuronal demyelination, it could be the chemical messengers. There are a lot of factors. This research is still ongoing at the moment, so we don't know what is particularly causing it. So there could be an inflammation in the brain. It could be genetics. It could be mitochondrial itself. You understand? So a lot of factors. So we don't know much about that at the moment. But I think once the research is more clear, then we will be able to find the pathways to treat this condition. At the moment, unfortunately, this condition is not treatable. So a lot of young people or the families have to live with it and understand the young person. Okay. So yeah, there are a lot of research still need to be put in this condition actually.
Thank you. Okay, if you got anything, can you pass it on to Sujata, please? Then
we'll do that.
Thank you very much. We really enjoyed. I learned a lot. Thank you so much.
Thank you.
Yeah.
I think Vimla Patel wanted to ask a question. Am I right, Vimla?
Yes, Sujata.
Yeah.
Yeah. Sorry, Dr. Sunil. I missed the major part of this talk, although I wanted to join it from the beginning, but I couldn't, so I joined lately. I'm a community worker, and I see lots of people suffering from autism or mental illness. Is this very more common in our children's generations than it was in our generation?
Yeah, I think you missed the initial part. Yes, it is 1 in 100 at the moment, as I say, 1% prevalence, basically. So that is that common. Yes, off late it's much more recognized and the awareness basically. So the reporting is more. So that is one way. And most of my pediatric colleagues, the early stages, they are recognizing it more. So by the time they reach to the mental health, these things have been recognized. So that is why we are seeing more cases. But the prevalence hasn't changed. It has always been the same, but it's more awareness of late. That is what I can say.
More awareness.
Yeah.
Yeah, I think before it was a community stigma and people were not coming out.
Totally. Well, even now the Asian families
but how
are still
can we make our Yeah.
So
But what I've seen nowadays, the children have become so weak-minded. So how can we make them the mind stronger?
well, I wish I could have a magic pill, Vimala, Ms. Patel, sorry. I know it's hard, but community workers like you are the main people there who can guide these people, educate them, educate the families. More important is education starts in the family, isn't it? So if I were you, I would definitely encourage the
that's
family
right.
to be more stronger. And that is how the strengths, I mean, obviously the families share that strengths to the kids, isn't it? I know it's hard because
Yeah.
the next generation are born in here, isn't it? We all come from an Asian backgrounds, perhaps. A lot of these generations and a lot of things we need to understand. So you are the best person to guide the families who have immigrated to this country from the community worker background to give that resilience to them and empower them to guide their kids to be more stronger.
And I think most probably because of lack of vitamin D, because we don't have sunny period all the time, whereas in India they've got 365 days the sun available.
I mean, you actually made a really valuable point, actually, Ms. Patel. One of the main research points, because it wasn't a medical kind of room, that's why I didn't mention it. Vitamin D has a massive input in causation of ASD, the autism. Vitamin D has been recently published as part of the evidence research. So yes, yeah, vitamin D will definitely make help. I agree with you. So yeah, that is one of the main confounding factors as well for probably autism.
Okay, thank you, doctor.
So, yeah, sorry, I missed that prevalence of between the female, percentage and the male children. Did you say it's more in female than the males?
It's more in the males than the females identified.
Males, okay, more than that.
Females are a bit later to be identified because. Okay.
Sorry, I think my own suggestion here, because I feel that autistic children are, we fail them on both ways, parental and then of course the government and the medicals. Most doctors, they have no idea of the way to treat these autistic children. And then of course, when it comes to parents are, especially when it comes to the mother takes, in our own ethnic setting, the mother suffers because of that. And then of course, the male part of it, or the spouse, seems to not to participate. And then of course, this child and the mother is left in limbo. That limbo is non-awareness, no education, and they have no idea of where to go. And then of course, the medical or surgery disappoints them because they have no clue of what to do with these children. So the parents and ethnic minority and the children are in a limbo in this country. So how are we going to sort it out?
Interestingly, Cornelia, can I just interrupt? Sunil? We had a project wherein we used to invite all the carers or mothers to come together. So they just open up and talk about their issues. It's just about feeling that another person is also going through the same issue as much as you are going through. It was a very good session where parents used to talk and open up, because as you said, they don't know where to go, they don't know how to talk, they used to share what's happening.
And some have the information, but they fail because there's no compliance between the spouses. And then that alone, they feel that child, or that stigma is there, and then they cannot come out. My daughter is a CEO of Hidden Autistic Voices. And the way she struggles with parents to bring their children so that they can help them, to give them that awareness, and then where to go to refer them, and how to go for, to get their diagnosis, and because some of them don't have an idea and they don't have diagnosis at all. So you see, that education there the surgery, they don't have any idea of it. They don't even know what to say to the parents. They don't know where to direct them. And then in the community as well, we have problems because of that stigma. And then the children is left in limbo. And by the time they, even if my daughter goes to their home to tell them, bring the children and then let's educate you, because she's an advocate to them, but they run away and they don't come out to come and, get the right direction or the pathway where to, they said they don't have the time. So, all these things are the things that, is really a problem, to solve, because the children are left unattended and they are left in limbo, and then they develop into the stages because there's no attention or any guideline or any medication to guide them, and then these children are left in a limbo and they develop into different stages, worse scenarios, that the children become worse, and then the family is all in limbo with with the children. So that is what, as the doctor said, they have referral to this educational sector and all that. But how do they get there? Well, who will start them? Will they come out for somebody to tell them where to go? These are the problems we have at the moment.
Can I if you don't mind, can I answer this one question for her?
Yeah.
I'm a retired GP, okay? So
Yeah.
GPs are very hard pressed, you know that. There are not many GPs around. People are leaving the jobs because it's too much work for them. And there is no funding to support all the things that are happening in this country. There is no money to support all this, what we want to be done. So basically, it is not nobody's fault. It is the country economy. They can't afford. They can't afford. They have no money. Even people are not able to eat properly. So there is a big problem because we have no money to fund everything in this country.
Sorry, money is not all, doctor. The problem there is most of the GPs, they have no good idea about autism.
Yeah, but
they don't.
I don't agree with that. I'm sorry.
And because they
some,
don't.
maybe you can say maybe some, but the GPs are very sympathetic and they want to do the best for their patients.
Yeah, they are sympathetic, but the direction of where they take them to is not, really the actual pathway because of their own poor knowledge of faith. Yeah.
Yeah, thank you very much. Sunil, you got to add anything? Thank you very much, Cordella. I really appreciate your input, what it is like, the system. That means there is a need for a project for those who need that kind of a support. So we are here to coordinate with your daughter's charity or group, and then we will work together. Over to you, Sunil.
Yeah. I mean, as much as to Cordelia or anybody else in this in today's session, basically, it's an eye opener for me. So I'm glad I really made it, actually, Sujata. And thank you very much for giving me this opportunity. Really, I'm happy to join for any future sessions, Sujata, if TMR holds this. Yeah, go on.
Thank you very much, Sunita.
I have a couple of questions in the chat.
Oh, okay.
Fazela would like to say, can you tell me about Asperger's? Is it similar to autism? And there's another question. Want them to do what we want, especially in class? I don't know what it is like.
I thought you were monitoring.
Above Fazela, you have that question.
Oh, sorry, it was my question. Like, as a doctor, what's your best advice to advise a teenager, or to advise a parents or a teacher or teacher assistant when a child with autistic, especially teenage or any age, when they're in meltdown time, and what we want them to do? So what's the best approach to them?
Thank you, Shweta. I mean, the basic approach is, well, I don't know if it's autism or anxiety or obviously the main thing is ABCs. ABC is antecedents, behavior, and consequences. What exactly was the main trigger for this meltdown? I would go to the basic sort of in-depth about it, actually. That is what I would start as a thing, right? So that is where I would find the triggers. It could be trivial to trivial trigger. Perhaps you or I may not be noticing it, but the young person notices. Well, I know it's quite tricky with adolescents at the moment in UK, well, the second generation perhaps. It's more important is the parents to be aware about the local kind of norms or the societal norms. So that is one way to look at it as well. So perhaps for us to understand it a bit more, right? It could be school pressure. It could be peer pressure is one of the main significant thing most of the Asian kids go across. So there are a lot of factors actually, Shweta. It's not one thing, but I would obviously go to my basics, the ABC. What exactly triggered this? What is the behavior? So why is this meltdown happening? And ensure that she or he is safe. Daughter, you said that she's safe, basically, and then reverse it back. Retrospectively, you need to work with it. So it is a process. It's not just one-off answer, actually, Shweta, but it's a massive process working with it. We can't just resolve it in one sitting. Yeah.
Thank you
Yes.
so much.
Thank you very much. There's one question, I don't know whether you answered. Can you tell me about Asperger's?
Yeah.
Similar to
Right. So
autism?
until recently, I know I mentioned about one classification called DSM-5, isn't it? That is our current kind of guidelines we are following. Until recently, I would say probably 4 years ago, this Asperger's syndrome name or label existed. The only difference between now we are not using it is it's replaced with high functioning autism. Asperger's syndrome is somebody who's extremely intelligent, academically well able. That is where then they were collectively called. For example, I gave you a couple of examples like Charles Darwin or Einstein and stuff like that. So these people were Asperger's or high functioning autistics. So yeah, but again, that is autism, but again, they're high functioning. When we say low functioning, the normal norm at the moment we are using for everybody's understanding is forget about Asperger's or different names. Autism or ASD. That's commonly anybody gets a ASD diagnosis, that's don't worry about whether they're high functioning or low functioning. Okay. So
yeah, thank you, doctor.
Sorry.
Thank you for explaining it properly.
Yeah, you're welcome. No problem.
Thank you.
Yeah, thank you.
Yeah, thank you all.
Sorry, I've had one last question, if that's all right.
Yeah, go on.
Thank you. Just wondering, recently I've heard in a lot of talks that the amygdala causes anxiety in autistic children. So I'm just wondering, the intervention for anxiety in autism, would that then vary based on that, or not really? You follow the same kind of intervention for anxiety then?
I mean, Miss Ali, I mean, you're nailing the right points actually today, because it was I didn't feel it was a medical kind of session. That's why I didn't touch on all this. Right. Autism, as I said earlier, was the initial presentation. If you remember my slides, it's emotions, isn't it? Emotions, understanding other people, sarcasm, jokes, humor, these kind of things. The main areas in our brain, probably Dr. Daniel and other medical people around might agree with me. We have few parts of the brain, especially the temporal lobe, the amygdala, the hippocampus, the cerebellum. These are all important areas at the moment. This is what I was trying to tell earlier as well to somebody else who mentioned about, because it's the inflammation happening. These are all hypotheses at the moment. A lot of researchers are working on this. You're perfectly right. The emotions are part of the amygdala. The emotions are part of that, basically. So I think hopefully, touch wood, hopefully we'll get some answers in the future course, because very good research is happening at the moment in regards to the hippocampal analysis or the amygdala analysis or the cerebellar analysis. Okay. So because a lot of these things have the mechanisms basically which are controlling, and they are working on it. Hopefully we'll get some answers. I don't know how soon, but let us.
And in your experience, have you seen any relation between the gut and the brain? Because they say inflammation in the gut.
That's an interesting point again. I think again it comes to the immunity, isn't it? It's because our gut has a different bacilli or bacteria basically, right? So what happens in that bacteria is it's a normal bacteria and it's a good bacteria. A lot of kids with autism, again, as I said, if I initially remember, the inflammation or the immunomechanisms basically, which also cause, that's one of the reasons a lot of people are prone for more allergies. A lot of people with autism doesn't like those textures. You understand? A lot of factors are there. Yes, it is linked as well, but very much preliminary stages at the moment with the research. So yes, there are definite links. I'm not disputing that. Yeah, hopefully we will get some answers sooner.
Thank you so much. Thank you. It was a great presentation. Thank you so much. Very grateful.
Thank you all for attending, and it was such a marvelous interactive session. I don't think we would have done it without you all participating. And of course, Dr. Sunil, thank you very much for being there here today. We come back again if you need any more sessions with Dr. Sunil or anybody else. And they're mentoring a charity based in Cardiff, but we are everywhere. We do get referrals even from England. And we would love to be in touch with all of you. So you can give us feedback with info@mentoring.org.uk or contact me on my phone number, Sujata 07790 900 263. And this is recorded and it's live on YouTube. Thank you very much. Bye-bye.
Thank you.